tender touch of sound. We felt the many planets spinning around. Shadows glow and shine. We saw the silent passing of our time. I saw the world change to please. We rode the boat through heavy seas.
Absence of a formal emergency medical system or formal ambulance system, how you would suggest to go about set up STEMI network up? And do you think it's viable? Do you think it's possible? Or in the absence of having many hospitals that are primary PCI capable, do you think it's good to go for a pharmacokinesis strategy? So that would be one question. And the other question I thought was about again related to that, because we have a long time for a patient to reach hospital. We often get patients who are beyond the time frame of thrombolysis or primary PCI. So patients like that, do you recommend like how late is too late to go for a primary PCI?
Right.
So we get patients who are beyond 2 to 12 hours, sometimes who are beyond 48 hours also. So that sort of patients, do you recommend going for opening up of an infarct-related artery, or do you think it's better to sort of take a conservative approach and then manage the concern?
Very good.
Do you think those are good questions?
No, I think that's great.
Okay.
That camera and then talk. This camera? Yeah. Okay, very good. No, sorry, you have to look at that camera. While you have to look at that camera.
Okay. All right. Hold on one second. I'll use the Professor Hadley Wilson.
Right, that's correct.
Okay, ready. Okay, good afternoon, Professor Hadley Wilson. So this is as you are aware, this program, the Sri Lanka Sri Lanka Heart Association sessions, is being streamed live across YouTube and on Facebook to some of our listeners and viewers in India and Pakistan. So we have physicians tuning in from the South Asian continent. Okay. All right, good afternoon, Professor Hadley Wilson. So as you're aware, the program we have today is being streamed live to other parts of the subcontinent in India and Pakistan. And for the benefit of them and for the benefit of some of us who couldn't take part in asking questions during your very interesting session on STEMI management and STEMI care networks, I would like to ask you one or two pertinent questions with regard to STEMI care in a country like Sri Lanka. To start off, we've been aware and we've been introduced to the number of programs that you've been heading in the United States with regard to STEMI care networks, how you set them up, and how you manage to get people within the recommended door-to-balloon times into hospitals and to get their primary PCI done on time. So in contrast to the United States, Sri Lanka is having far less resources, and in fact, we don't have a formal emergency medical service yet. So how do you recommend that we could go about this in contrast to what you set up there? Do you think we could start off in Sri Lanka as well? And would you be able to give us some advice or some tips on how we could set up a STEMI network here as well in Sri Lanka?
Thank you for your question. I'm honored to be here and to help participate in this exciting academic conference here. So it's a very interesting question, and as you point out, every region, every state, province, country has its own unique challenges, obstacles for optimal STEMI care, and I think you have to analyze each situation. We did point out earlier about the Global STEMI project, in which we are actually trying as a first line to look at available centers that are able to provide either PCI or pharmacologic fibrinolytic therapy for patients, and then think about developing transportation systems and networks and so forth. But much of that comes much later on, sooner hopefully rather than later, but it does take time to develop. I'm very impressed with the hub and spoke wagon wheel type project that is going on with Dr. Rana Singhi and others here in the Colombo area with 7 hospitals or so in the 3 levels of care, including first medical contact all the way to pharmacologic and to transport for PCI. Another program that's going on also through the ACC that is being pushed out in this global STEMI project, which I think is very relevant here, is to actually identify what are the resources in the particular regions and the countries of the world. And the first idea would be to go through a region or a country and identify exactly what is available to patients with STEMI wherever they may be. Is it just a health center? Is it an ambulance? Is it a local office? That might be like a first point of contact, and be able to identify those areas throughout a country first. And then secondly, then look at the second level centers that may actually be able to provide pharmacologic therapy, fibrinolytic, thrombolytic therapy, and identify those. And then, of course, thirdly, as you have done here in Colombo, identify the level 3 centers for PCI or even primary PCI, or receiving centers after those patients have been identified in their region and either had transport to a pharmacologic place where they could get thrombolytic therapy, and then ultimately to tertiary quaternary center here in Colombo or another city, or may even be directly transported depending upon the resources. So to summarize then, I think the first part would be to identify exactly what the resources are, what available point of contact resources there are throughout the country, and then begin to think about how those may be linked to the next step, either thrombolytic therapy or possibly even ultimately the PCI center.
Thank you very much. So in other words, do you recommend that we sort of set up a central coordinating center where patients with STEMI could be coordinated from depending on where their first medical contact is, so that in case they go to a GP, they could straight away be sent to a PCI-capable hospital without going through to an emergency department. So to have some sort of a centralized system, maybe a centralized coordinating office so that patients are immediately transferred to the regional PCI center bypassing the emergency department.
That's an excellent question, and if I think I can answer that correctly, I would say that any of these programs require strong leadership and a strong team approach and coordination, and certainly telemedicine can be very helpful for that, also even in transporting by ECGs, by email or text or WhatsApp or whatever is available through internet resources, to where those STEMIs can be diagnosed, and then to have a read back as to where that patient may be transported. So these are all great questions, and I think that having the leadership and the team approach, and then secondly, as I mentioned earlier, actually last night in our conference, is that if you can start to develop registry data about the performance and the outcomes of those patients, then you can look and see the times are good or the times are not so good, and this is how we may improve that, and then also the outcomes of the patients as they proceed to these higher levels of care.
I think we got a good idea of what you're suggesting, and I think it's time that we sort of set ourselves about getting it done. So further to that, going on from the logistical aspects to the more clinical aspect, as I said, due to the same lack of resources that we experience in our country, sometimes patients come to us very late in the day. So you get a lot of patients who come well beyond the stipulated 12 hours after MI. And according to the guidelines, you could still go for a late primary PCI up to 48 hours. Suppose a patient comes after 12 hours but before 48 hours, and it's probably an evolved STEMI according to the ECG findings, and patient is not in pain now. Would you still go ahead and do an angiogram and open up an artery in the absence of pain, even though there is ECG evidence of an evolved MI?
That's an excellent question, and I think the guidelines would say that those patients past 12 hours that are not having chest pain, in spite of ECG that shows STEMI, should probably be treated conservatively. And that may be interesting or perhaps even humorous coming from an interventional cardiologist, but I think that is correct. Certainly, as I pointed out earlier from the culprit shock trial, if they are in shock at any time, 48 hours from onset of STEMI, then they should, if possible, be transported and go to the cath lab as a life-saving procedure. But short of that, unless they're having evidence for recurrent chest pain, or perhaps there is some early study of stress that may reveal ischemia in that area or viability, then we would treat those patients conservatively past 12 hours. But we would probably try and obtain some type of information of viability within the first 30 days, and if so, proceed with cath, angiogram, and PCI at that point, if appropriate. If it showed no viability, we would continue to treat them medically.
All right, and conversely, if you get a patient who comes to you 48 hours after the first episode of chest pain, and now he's got a second episode of chest pain, something similar to a post-MI angina, or he's been having on and off chest pain for more than 48 hours, and the ECG shows an evolved MI. In that stage, now it's after 48 hours, the guideline says go ahead and do an angiogram up to 48 hours, but this patient comes to you after 48 hours. Would you still, what would your approach be in this situation?
That's another great question, and I don't think that we absolutely know what the right answer is here, and it would be somewhat in the purview of the clinician who was taking care of the patient as to whether or not they thought that this patient was continuing to have stuttering type on and off chest pain past 48 hours, and then that would be reason to proceed with an angiogram versus post-MI pericarditis or some other cause of chest pain. Very difficult question. I think, again, this would just really require good clinical acumen to determine what is best. I would favor, if they are having chest pain of any variety after 48 hours, to proceed with an angiogram.
Just one more question that seemed to be bothering us when we were in the cath lab from time to time is, suppose we get a patient like this, and then we decide to take to the cath lab, and then there is a complete occlusion, let's say, of the culprit artery. What would be the disadvantage in opening up a culprit artery after a 48-hour period? Is there a particular drawback, or what is a negative outcome of opening up a culprit artery after such a long time?
Another great question. I mean, this is certainly an area of heavy investigation right now. And if you are in the camp of the investigators who believe that opening blocked arteries, so-called chronic total occlusions, are favorable, then this would be a reason to consider doing an angiogram and opening that artery. Obviously, that's not a chronic total occlusion because by definition that needs to be more than 3 months. But, you know, it would be what we would call subacute or not necessarily even an acute if it's after 24 hours. But there is growing data of the open artery hypothesis that not only does it relieve symptoms primarily, but that there may be long-term benefits of LV function improvement and also symptom improvement downstream. You know, certainly many of these people can be treated and managed well medically, but they may not prefer to take 3 or 4 anti-anginal medications, particularly if they're middle-aged and they want to be more active. So I think that this is an area still of debate. It's not sealed one way or the other. And I think that it would certainly favor consideration of going ahead and opening the artery if the patient was otherwise clinically and hemodynamically stable, and they could take the contrast volume and so forth. So
is there a risk of
you would have some that would say go ahead and manage them medically, and that I would not disagree with it.
Right, okay. Is there a risk of reperfusion injury or reperfusion, like opening up, like in limb ischemia, if you open up an artery too late, there is a problem of reperfusion and reperfusion injury. So is it same with the myocardium? Do you get reperfusion injury by opening up it too late?
Again, another area of research that's been debated for decades is there reperfusion injury, and I think it's very difficult to assess that. So I would say that there probably is no harm beyond the actual risk or complications of the procedure itself. So I would say it would, in general, would be low risk, hopefully in the 1%, perhaps 2% range, but should certainly be considered. And the best way would be to also discuss this thoroughly with the patient and their family outlining the risks, and also even as it's becoming more popular now, a heart team approach with your colleagues, you know, asking them, do you think this is the right thing to do?
Okay. Thank you very much, Professor Hadley Wilson. It has been an absolute pleasure, and thank you so much for taking your time off lunch hour and talking to us and enlightening us further on the topic that you discussed earlier. Thank you.
It's been my pleasure. Thank you.
Well, if you should ask me the amount in my bank account, I must